Yeah, I mean, over the years, so I'm now 40 years in the orthopedic business, 4 decades, and a lot has changed. A lot of things have showed up again, and so I would like to give you my experience over the years, what seems to work and what doesn't seem to work. So this is a lot of data probably, but I mean, it's important to know what you select for the patient. So when you go to implant selection, you shouldn't rely only on the company or the rep, what they tell you, because to be honest, I had bad experiences to rely on what the biomechanic guys told me, especially in metal on metal. So this was a disaster, but at the beginning we were convinced according to their data that this will work in the patient. So not all what is evident to be good in the lab is good in the patient. So this is important, and over the years the things are changing quite a lot. So we have for selection a variety of stems, and I mainly focus on the stem because the cup is very simple. I mean, it's hemispherical. Screw cups are not used almost at all. And here you see in one picture the differences, and there are numerous different components, and which one is the best one to detect. Of course, you can go to registry data, but this may be not the right implant for you in your setting, in your surrounding. So here you see extreme differences, and of course cemented or cementless. The question remains, do we look for the patient and then select the implant, or do we take one implant for all these patients? So there are different situations where we have to be more cautious with implant selection, and this is just an aspect of it. Registry data here, a summary of different registries shows that we have an excellent long-term follow-up. So 30 years, 30% of failure. So this is a rule of thumb on the, it's not the benchmark, but it's a rule of thumb. But these are all data. And what I've seen over the years is a tremendous change in activity. I mean, 30 years ago we treated patient for pain. That was the situation. They were happy, but nowadays they are not. So they want to be active, and they want to be really to do all their sports. So I mean, to compare, what the biomechanical testing was for how many cycles usually? Do you know? 12 million. So this was the standard. To do a cycling, a testing for wears for 12 million. Why? What was the yearly activity of a patient? What do you think? How many cycles, gait cycles? A normal patient, how many cycles does he do in 1 year?
At least 100,000.
Well, a little bit more. 1 million. But this is an old patient. And the active patient does 5 million cycles. So can you imagine? I mean, after 2 or 3 years, the situation is like in the testing we were used to. So this is a complete difference, and this has to be included when we look more thoroughly into details. Here's, for instance, from the Australian registry, a difference showing here titanium and titanium necks, and here titanium cobalt chrome. So here see significant differences in some aspects, and especially in very active patients. So when we select, we have to look at durability of the implants, safe implantation possibility, anthropometric fit, and the reconstruction of biomechanics. And what I would like to discuss with you here is standard implantation, what we do in the old patients, in the geriatric population, what's about in short stems, which is a hot topic. Are you using short stems? Oh, who is using short stems? Very rare. And the question is also, what is short? And then here, just one back. And the difficult primary, we have seen one aspect before. Here you see the anchorage. So just bear in mind what this looks on a micro basis. And you see here, very simple, in the cementing technique, you have a big interface between bone and the implant and the bone and the cement. And here, this is the early Zweimüller, which was developed in our clinic by Karl Zweimüller. And here you see here the integration, the osseointegration, the attachment of the cancellous bone to the implant. Severe osteoporosis in the cortical bone surrounding the stem. So this is maybe an issue which leads on the long-term run to higher periprosthetic fractures, which we'll see later on. Here you see different possibilities of osteointegration. We know grid-blasted, plasma sprayed surfaces. We have fiber beads sintered to the surface, fiber mesh. And we have bioactive surfaces with hydroxyapatite growth factors, but this is more on an experimental basis, and dicalcium phosphate. So what is the best surface layer with hydroxyapatite? How thick should it be? No? No. Not more than 100 micron. So it should be less because on the other side, usually the best is about 30, 40 micrometer, because otherwise it will detach and you get a new interface between the implant and the hydroxyapatite, which is attached to the bone. So we saw loosening in cases between the prosthesis and the hydroxyapatite if you have a thick layer around the prosthesis, and especially if the primary stability is not good enough. Here you see different roughness of the surfaces. It's also important. What is the best roughness? It's also important for bone substitutes. So it's about 150 to 300 microns. And here you see grid blasting is not at all, it's too polished. And it's not attracting the bone. This is important for vascularization, for vessel ingrowth, and of course for osseointegration. So this is, I mean, it's a pretty standard over the time now, but just to know it and to be aware of it. Here you see this implant by Zweimüller, developed at our institution. It's really, it was a working horse and provided a benchmark because of the excellent outcome. It was modified over the time. So when I entered in '84 in the University Clinic in Vienna, we had this old stem with it was a rectangular, but not like this one. This was plasma spray, it had a good surface, and it worked really excellent. We have now data more than 30 years, which are published. And here you see the first case is 86 with this new implant, because in the older ones we had polyethylene cups which got loose and caused severe bone destruction. Here was the screwed cup, and this is the result of just the stem. You see here 20 years with 97% survival. So why to change? Yeah? I mean, this is the question. Here you see excluding the polyethylene liner, but including the acetabular liner, we had 88%. If we include the polyethylene liner, it goes down to 67%. So this is the problem. Where is the problem? Why is where the problem on the long-term run? Sorry? Yeah, what is it causing? The where? And why? Sorry? Sickle cell? Oh, did I? No. No, you know the mechanism of loosening. I'm sure you know. I have no slide. Unfortunately, I've forgotten it. But this has been detected by Willard. These wear particles, they cause activation of inflammation. So macrophages are phagocyting, are eating these particles. They're coming to death, and all these substances which evident in this situation, they activate the osteoclasts. So we have a certain threshold of size of particles which are more bioactive, meaning they are more activating the macrophages, and those are really then initiating the cascade leading to osteoclast activity. So you get an osteolysis along the bone implant interface from the effective joint space down. And it's going around the cup and going down. So this is important, and these particles were about 10 to 50 micron, and this was the disaster with the polyethylene, with the old type of polyethylene. Now here you see a summary of different registries focusing on uncemented prosthesis, different types. So the Zweimüller is type 3C in this rating here, and you see here that all different stems which are used in the registries have comparable revision rates. So you could use any one of this. Here you see the most frequently used one, the rectangular types, Müller, Zweimüller, and Spoto, and you see here the 12 to 13 years follow-up. Being excellent and a little bit better for the Zweimüller stem. So this is a good working horse. Here you see a study out of the registries comparing directly cemented and uncemented components, so stems. And in this situation, there was no difference. So if this is done really well from a technical point of view, cemented or uncemented implantation, you have similar results, but this doesn't show the same in the registries. This is the NARO registry, so the Scandinavian arthroplasty registries, a summary of the different ones of Denmark, Norway, Sweden, and Finland, and you see here significant differences in the fixation technique. Cemented being blue and predominantly used in Sweden and Norway, where it was less in Denmark and Finland. Although the age groups were similar in all these different countries. So there were different habits how to use these implants. And here you see the survival rate of cemented and uncemented. And we see here that the curve is pretty similar in the cemented technique, but there is a difference in the uncemented, being better in those countries like Denmark, where they had more experience with it. These are survival curves for hybrid, cemented cup, cementless stem, very similar, but big differences in the so-called reverse hybrid arthroplasty with uncemented cup and cemented stem. Are you using hybrid or mainly one technique, cemented or cementless? Who is using hybrid? Okay, very good. Mm-hmm. Which, the standard or the reverse hybrid? Sorry? Standard. Standard. Okay. This shows that by time the rates of survival improved. This is due to technique, but also due to implants, both in the cemented and the uncemented group. And age makes a big difference. Here you see the arthroplasty, the survival curves in the young patients, which are much lower than, of course, in the older patients. It's not surprising if we know the different cycles, how many cycles a patient with 55 years, especially a male, does, or an old patient. So that's the real reason how they are doing. But on the other side, we see the so-called pyridoxine. Also in these Scandinavian countries, we had a decrease of the cementing technique over time. So who knows why? It's called the Swedish pyridoxine by Henry Malcolm. And this shows the switch here, the switch over in 2011. Now let's look to another very famous registry, the Australian one, very well established, and they use similar techniques as we do here. in Austria, cemented very rarely, cementless in most of the cases, and hybrid in about 35%. These are the failure rates, accepting loosening being still the most common one. Dislocation, as we heard before, is increasing, fractures, periprosthetic fractures, and infection. This is here the survival for cemented and cementless in osteoarthritis. And if we look by age, we have a higher loosening rate in the cemented technique in the young patients. So below the age of 55 years, cementless fixation is the method of choice. Obviously, it's the same from 55 to 65 years, and even between 65 and 74 years. So still uncemented being better, but what's about, you see it in more than 75 years, patients with cemented technique and hybrid had an improved outcome. So this leads us to the difficult geriatric population. So do we cement them all? Some of us do, but it's questionable if this is absolutely necessary. So mortality rates in register differ. So here you see the Norwegian arthroplasty register, and you see that total hip arthroplasty patients do better than the general population. Why is this the case? Yeah, and it's also a selection bias because we don't operate on the patients with morbidity patients, and it's sorry.
In our countries, we are beginning to operate everyone. if we.
You have to operate on everyone.
Depends because small countries, professor.
Yeah.
And for example, if I don't operate today, maybe I will not operate tomorrow.
Yeah.
If a patient comes in, maybe I should do everything to
Operate it.
prepare him for operation. Even though to take the risk for dislocation, infections, and everything. Maybe.
Yeah.
It's a little bit.
But do you have an age limit, saying above 80, 85?
Of course.
Yeah.
If the patient is
100 years?
say, yeah, 100.
Yeah.
I don't think so. We will operate a 100 years old with total hip replacement.
Well, but 96, 95? Yeah, it's an issue. I mean, in some countries it's limited. Yeah. So.
You said before that the expectation of the patient, for example, if you're 90 years old, you want to be active, I think you will operate.
Yeah. Yeah, exactly. It's so different, and it's the chronological age on one side, but the biological age is so much different in some patients, and they have no problem also perioperatively, and this makes it difficult to select these patients. Yeah, so these are the data, and we have also, as you can see here, in the younger 60 to 79, an improved outcome. This is under magnification the curve for the old patients beyond 80 years, and you see here in the initial phase you have this decrease, and this is important. So the 90-day mortality is extremely important, and this requires a meticulous management of these patients in general, not only for the hip. You have to take care of all the comorbidities of these patients, be aware and be proactive in correcting this. Otherwise, you get into this problem here. So if they are over 3 months, they do very well, and usually they are on this better curve here. So what they found also, a lower mortality rate in uncemented compared to cemented total hip arthroplasty. This applies for the elective surgery. I don't talk about fractures because it's another issue, and you are better on with cemented prosthesis because of initial stability in these patients. Yeah? This is for osteoarthritis. Here data from the States, from the Rotman Institute, showing also the curve, a higher mortality curve in the general population compared to primary and revision arthroplasty. So again, this is a selection bias of these patients. And they do not better because of the operation, but maybe also because they stay active. So nobody can tell at the moment. This is a big analysis from McMinn from the English registry, and it shows that mortality rate in the uncemented is is higher compared to the uncemented also. This is interesting over the years, not only perioperatively. So this caused a big discussion, this paper. Nobody knows exactly what's the reason, but we have to face this fact. Although the uncemented had a little bit worse outcome on the long-term run. So here's our analysis of patients over the 80s. This is not a recent paper, it's already published. So 250 patients more older than 80 years. So the mean age at surgery was 83.6 up to 98.5, so 100 years was in one patient. And the mean follow-up was 36 months. All were treated with the Zweimüller stem and threaded cup or a standard cup. And here you see the high numbers of comorbidities in these patients. I want to get through them all. And these are the intraoperative and the postoperative complications. So intraoperative death, 1, 2 had a stroke. Trochanteric fracture is an issue, but especially with this type of prosthesis because you are violating the great troch during the preparation, and modern techniques, modern implants could provide this. Femoral shaft fracture in 1. These were postoperative complications. Here you see the late complications. 1.7% periprosthetic fracture, it's acceptable, but it's not 0 to be honest. And infection 2.5, it's also higher than in the standard group we are treating, and we have an infection rate of about 0.5 to 1% over the years. And trochanteric pain is also due to the approach, and at this time the direct lateral approach was used in all the cases, and this in combination with this implant causes a high number of trochanteric pain. This is the survival rate acceptable, but still higher risk than in the younger patients. This is a very dedicated institution, the Rotman Institute, so they are not a training clinic as we are, and they had even better results, 80 to 134 patients between 80 and 90 years. So no intraoperative death, no fractures, infections, or dislocations. So if you are well trained, if you are a high volume surgeon, you can treat these patients very safely without cement. So this was also a cement-less total hip arthroplasty. And this is important also which shape we are facing of the proximal femur. We have a so-called champagne flute shape, type A femur, type B, which is between A and C is the wide canal, the osteoporotic patients. So this is the fracture patient you are facing usually. And here you have situations between B and C where you can think about this. If you have a type C, you should go for a cemented because it's not getting rotationally stable unless you use this big implant of Zweimüller, which is fixed distally and provides high rotational stability. So what helps in this situation is the so-called collar, and I will go a little bit deeper into this because nowadays a lot of companies are refreshing this feature, which was present a long time ago, but a lot of companies are providing this. Why? Because it increases stability, obviously, but it has also disadvantages. Yeah, you can get, if you don't go for a good press fit, you get the cantilever motion here. Oops, this was too early. a cantilever motion if it's fixed only at the collar. So this is somehow tricky to implant it. But in the lab, you have excellent stability. Both axial, as you can see here, this is the vertical stability, and here you have 10,000 Newton until breakage, and you have 8,000. So this is a big difference in implant stability, and also the rotational stability increases significantly. So well done, it helps and it provides a better outcome. This is a study we did during the development of this product here. We had it with and without collar, and this was the comparison. The Trilog stem, a very stable stem with an excellent track record in the registries, in the American register. And you see that we had the Actis with collar and the collarless. We had a significant increase in rotational stability, stem subsidence, and also a higher load to failure, which was necessary to fracture this construct. So what does this impact the clinical outcome? These are data by Johnson, which were not published, but they were taken out of the English register, and they compared 65,000 cori with a collar to 65,000 without collar. And what was the outcome? You see here in blue, you see all other types of cementless prosthesis, which were similar to the collarless prosthesis. And in green, you see the prosthesis, the cori with a collar, and this performed significantly better. And this was the initiation of this new introduction of this feature. Here you see significant differences in the revision due to pain, dislocation, aseptic loosening, and especially periprosthetic fracture. So there is a reduction in periprosthetic fracture with this feature. You get all these slides in the layout. Here, this is a study again from the British registry, and they compared more than or analyzed more than 300,000 cases. So a big, huge number. Michael Morlock was involved, and he gave me these slides from the very beginning when the study was not published. It's yet published, and you see here the data. They analyzed 330,000, and they looked as an outcome for periprosthetic fracture. Here you see the 90-day probability of periprosthetic fracture, extremely high in the beginning, but lasting over 10 years. So there were always cases popping up. They analyzed different features and what led to, or what was preventive, or what increased their risk. And here you see that a collarless version increased the risk significantly. It was also a round stem, so when you don't have enough rotational stability, there were designs. I remember one designed in Austria, which was a disaster because of this missing biomechanical stability. And here you see taper. Taper is increasing the risk of fracture, obviously, because I mean you have like a cone working into the bone, and at least during the time of good osseointegration, there is an increased risk. What was not analyzed here is the loss of periprosthetic bone over the years, because you have stress shielding in some cases and a loss of the periprosthetic bone. This could also, of course, increase the risk. Here you see a situation with a demanding situation for the construct, a high pathological offset, which of course has to be reduced. But especially in these situations with high offset, surgeons more and more prefer the Kalka version because it gives you additional stability in the medial part and a good support. What was also interesting over the years is to see that this gap here, you see a press fit, and from the beginning there was no contact, and even after 5 years you see that this had closed. So this was no subsidence, but this had closed over the years. And the loading of the calcar, which we see in this case, is much better than in other short prostheses, where you get a smooth thinning of this cortex or even loss due to stress shielding. This is an analysis of 5 studies with cementing. I mean, they analyzed also the calcar. This is published very recently, but you have to go very deeply into this paper to see that 5 out of these 5 studies, in 3 cases, they used cemented prosthesis. So you wouldn't have a benefit in a cemented prosthesis of a calcar. But this is not mentioned during the whole paper. Just if you read the articles of the original papers, you'll see that 3 had cemented. These were prospectively randomized trials, so very well done, but the method was different, and this doesn't show the benefit. So let's come to short stems. What's about short stems? Is it good? I mean, some of you are using it. No? Why not? Please. Just tell me your concerns. I mean, it should be obviously easier to implant a short stem because, I mean, you don't have to expose it like in the lateral approach. You have to expose everything. And with a short stem, you can insert it very easily. So you have a reduction in soft tissue trauma. And that was the big advertising argument why short stems should be used. They are not new. I mean, this also has been developed over years. So it's bone sparing, that's true, but I told you that you get in some cases stress shielding, and by time you also lose a little bit of bone. The fracture risk is reduced because of bone preservation. That's a wish, I would say. It doesn't work in all designs, and the reduction of stress shielding, also this doesn't work. So what is small? This is really a small implant. Have you ever seen it? No. I mean, this was on the market. I implanted some of them in 2000, since 2010. It's the silent prosthesis from DePuy. It worked very well, and you just spare the complete column and put it into the column here. This is the Spirem prosthesis, which had a thread. And the thread was just in one side, so it worked on one side. I can't tell you which one, and the other side they got all loose because they were turned out. So I mean, these are funny things, but to know. But for the patient, it's not really fun. This was the Esker prosthesis with a rough surface, a real big mesh. This worked quite well. Some of them implanted it also from a Ludloff approach, from medially, because you just need a small hole to put in the prosthesis. And this is the Mayo implant. This was very old and worked in some situations very well. Those who had experience with it could get good results, but the revision rate, the minimum of 1 to 7 years, was 10.7%, which is quite high, meaning 2.36 revision component years. Do you know this term, revision component years? It's important when you read registries. You sometimes get this data, especially as was was established by the Australian group. And what does it mean? If you have different follow-ups or even short follow-ups, you have to calculate the revisions for 100 component years. So you put the revisions in relation to the long-term follow-up, and so you get, by multiplying this, you get a more comparable outcome between the different implants and between different follow-ups. So revision 100 component years of 1 means that you have 1% after 1 year and 10% after 10 years. So that gives you comparable results. Yeah? So 1 is good. but 2.36 is not acceptable, as I mentioned before. So 10% after 10 years, it's acceptable. Here you see different short stem designs, and there are also scores how to describe them. I think this is easily to understand: the column sparing, the partial column sparing, and the trochanter sparing. So the column sparing are the extremely short, which I showed you now, and they are not used at all anymore. These are the partials column sparing. Nobody can tell you exactly from where to where, but they are fixed in the metaphyseal region. And these are the trochanter sparing designs, meaning they're working around the calcar. They are usually curved, but the length is not the main issue. Fixation is important, but sparing or not violating the trochanteric region is extremely important. I don't really understand why this design here, which is the proxima, is under this group, because the proxima takes off a lot of bone from the trochanter, although it doesn't, of course, make a slot into it like the Zweimüller did, but still it's a bulky implant. Here you see that the length differs between the different stems, and it's important to see the biggest ones. I mean, the small sizes are small in different companies, but the biggest one, they sometimes are extreme. So like from the Korai, we have beyond size 12 extreme long implants, which do not spare the trochanteric region at all. These were early outcomes according to this rating, revision per 100 component years. And you see here in the column sparing, they have all higher revision rates. There are dropouts, of course, but these are in all other types again. Partials column sparing are better, and trochanter sparing are the best. Interestingly, here we see that the Optimus has a bad outcome with 3.17. So this was early, but this has changed, and now it's one of the best implants. So either partial column sparing or trochanter sparing seem to work. Here are some registry data comparing Australian and Netherlands and the different implants used. What was interesting to see here, the curves of frequency. You see in the Netherlands, they were very cautious in the beginning and then caught up and at the same level as the Australian register, which developed the use continuously. Here you see the outcome a little bit worse in the Netherlands, maybe because of experience. But if you have an excellent implant like the Optimus here, you see similar outcome in both countries. These are data from the Swiss arthroplasty register, and you can see here that even in this good outcome, improvement is still possible. You see the ActiStem here, which is the Optimus mentioned before, is the red line. This is the Amistem, the red line is the Optimus, and here you see that the Actis is even 50% better than the Optimus, so with an extreme low revision rate, and this is also covered in the American register with similar results and longer follow-up because it was introduced 6 years ago. So difficult primary, what we do in such cases. Is this good? Does it work? So it's interesting. I did this side here, but this still works, and this patient is still under my control. And this was done, I think, probably more than 15 years ago, yeah, or even more. So, and if you look to the second side, it's even more interesting. So, if you get good osseointegration and have a low demanding patient like this one, even you can go along with this reconstruction even. So, but usually we try to do it more thoroughly. So this is a difficult case. What do they do? 14 years old patient, avascular necrosis, impossible. Sorry?
The anatomy is totally destroyed.
Yeah, it's a dysplasia here. It's avascular necrosis. So I mean, preserving the joint is impossible. You can't do osteotomy. You can't do. I mean, you can go for an arthrodesis, but who does an arthrodesis? I saw only one arthrodesis in my life. Imagine, this was my former chief did one in a patient. I think it was 86. So this was the last arthrodesis I saw, and which was done in our clinic. Yeah. And this here, yeah. So we go for arthroplasty because I mean the patient, although he's young, so we are used from tumor patients to treat them also with metal, with endoprosthetic replacement. Now how to proceed? So first of all in ones or removal of the implant and then of the plate and then endoprosthetic replacement. Who would remove the plate first? Only one? Yeah. I mean, it depends. There is more and more tendency to remove the blade before. Yeah. Why? Because sometimes you have a different approach, and if here you have to do it from lateral, and you use then a direct anterior. I wouldn't go for a lateral approach in this patient. And or you use a posterior approach. Of course, you can do it also in this case. Yeah, this was done before, but then it doesn't look better. So the question is what to do. Osteotomy, 3D implant, so individualized implant. What do you think? Or send him to somewhere else.
Maybe osteotomy and modular stem.
Yeah, and which stem?
Modular.
Modular stem, yeah. Yeah, modular stem is, I think, very important. It's a good option. And osteotomy, yes, but then you have to fix it more distally, yeah, because...
you need to identify the abductor attachment.
Yeah, this is crucial, no question. Yeah, yeah, so I mean, this was treated here with this modular stem, as you can see here. And it's funny how, I don't know if I have a second, yeah, this is another case. Oops. I have not the axial view. Of course, it's not that oblique here, but it's completely stable and well anchored. And it's interesting that with this implant, you have only osseointegration here because this just provides rotational stability. This is a stem with fins and slots, so it's just for press fit for initial fixation and stability, but the long-term stability is provided by this sleeve here. So this is very easy, and the big advantage is here. It's a monoblock stem, and this is a sleeve which is modular inserted, and you can rotate 360 degrees wherever you want to put this. And this is a big advantage for this complex cases. Of course, you could do an osteotomy, but this makes it not easier. There's another case, interesting, 35-year-old lawyer, achondroplastic patient, had also osteomyelitis, so no head, complete contract situation. What to do? 3D implant. Do you use 3D implants? Individualized? No. But in this case, it could be thought about, and I mean, there is no ruler between, but this is extremely small, thin. And the only way to go around this with small implants, I mean, this is a modular. There are also other ones which should get in this tiny dimension. And here you see the implantation, the augmentation with an allograft here. And this is a fenestration. You know why? Sorry? No, I didn't do osteotomy. No, this was a complication during the operation. No, because the reamer, the stem, the probe, detached and was in and could get it out. So I had to open it here distally. But yeah, this is life. That's normal life. Anyhow, this healed completely. So this is the situation of in 2008, and this is 5 years later. The patient is still walking on this, and interestingly, how this allograft osseointegrated, so how it fused with the bone. But of course, this patient is not highly demanding. And you know what size this head is here? 22. It's a 22 millimeter head. Yeah? We have to put in, because it's so tiny. The cup is about I think 38 millimeters. Good. This is we saw this before by Christoph Böhler already. DDH, CRO4 or Hadophiliakides D. Here you see the technique of reaming, shortening, and putting in this prosthesis. There are different options how to do the osteotomy. The most simple one is the transverse. I prefer this one because this makes it more complicated, and even in this one are not really useful. And the graft you take out, the autograft, you just split it and fix it, and this gives additional rotational stability. So this is very easy and comfortable during the operation. So what's about the modular necks? This is of course not a typical modular neck, but modular necks and modular systems help you addressing complicated cases. But the concern is what? In this modular systems, fracture, yeah, because of corrosion, and this is a big issue. And most of the modular systems have been retracted from the market because of these problems. Here you see the outcomes, which differ significantly, 85 to 100%. So the summary of this review is they help you in restoring the anatomy. The body weight plays a role, so not in obese patients and in high offset patients, because this increases also the risk. And what was a fault in the design in the beginning was the cobalt chrome neck. So a titanium body and cobalt chrome neck was a disaster because this led to corrosion and secondary fracture. 3D arthroplasty, I mentioned it before. We don't use it also in the stem, not at all, but it's a possibility which has to be mentioned. But the evidence is poor in the literature that this is a recommendation for daily use or for different difficult cases, because these modular systems help you to adapt more better to the local situation. One word to hypersensitivity. Do you believe that's existing or not?
Me personally not, but my other department believes. So
Okay, so big conflict.
we have like every month one person which is,
Oh, really?
which is given anti-allergic
Mhm.
implants. So but it's,
In the knee or in the hip also? In the
knee.
in the knee, yeah. The knee is more, yeah, evident. No, it's not evident. There's poor evidence, and also in the hip. In the hip, it doesn't play that role like in the knee joint at all. But with the metal-on-metal bearings, of course, this was an issue. So you get this type 4 allergic reaction. But this is a production of a big debris. In the metal-on-metal bearing, and that was the reason why there have been abandoned. But in the with implant, the implants are usually made of titanium, except the cemented implants. So it's hypersensitivity is still a matter of debate. It's not proven. There is not enough evidence that this is the case. In the knee joint, there's also one study comparing outcome with and without anti-allergic implants. in patients who have a positive testing, and there was no difference. So we discussed this over 30 years, and there is no solution up to now. So it's a matter that if the patient knows about this, you have to discuss all the options and tell him. Especially in the revision situation, it's difficult because you don't have implants which are covered by anti-allergical material, and then you have to talk to him exactly what would be the best option and the safest solution. So we have still time, and I'm not finished yet, but just to summarize, we have this increase in cementless fixation all over the world. So it's a paradoxon called in the Scandinavian countries. We have superior results below the age of 75. We have a reduced mortality reported. The hybrid fixation is a good alternative beyond, or the cemented stem. The short stems have more and more evidence to provide good and excellent long-term results, and it's a valid option. It's not anymore experimental at all. And modular designs should be restricted to selected cases only. So we still have to talk about the bearing issue, and here you see a picture from a company showing very well what is the difference between ceramic on ceramic on one side, and here metal on conventional polyethylene on the other side. So there's a big difference in this old survey here between the countries, and even nowadays there's a recent paper showing that at least from these Australian different registries, that in the Swedish we have metal on polyethylene as a standard, but in German-speaking countries and also in Austria, the standard is ceramic on polyethylene. What do you use, metal or metalhead? And polyethylene. Is it good? Sorry? Ceramic. But do you, I mean, an active patient, do you treat the same as an old patient or? No.
We put ceramic in younger.
Ceramic on ceramic? Okay, yeah.
If it's very young, we
Yeah.
go for ceramic.
Mm-hmm. Yeah, this is good to make it tailor cut to the patient. You know, here, this is, I mentioned 22. When you ever saw one, I mean, it's so tiny, but this, when you go to Rhintington, where Charlie worked, where his lab still exists, you see how he tested 22 millimeter heads up to 46. You see here the difference in wear, so a significant increase, and this is the reason why in in former years only the small heads were used. Nowadays we have a standard of 32 millimeters all over the registries, and rarely beyond 36 millimeters. These are the 36 in gray, Denmark and Germany predominating. And we have nowadays, as mentioned also in the first lecture, this double mobility cups. Yeah? And you see a significant increase in the Swedish registry, yeah, from 2016 to 18. So in primary cases, also in the revision, of course, but especially in the primary cases. I mean, to have a good range of motion is obvious. Patients nowadays also, what do you do with a ballet dancer? Would you put in a triple, dual mobility cup, a 36 millimeter head? So this is an issue. So patients are really high performing, they are demanding, they want to do their activity, their sports as they did before. And how to increase the range of motion, either by the head size is clear, but the taper diameter, but this is limited by the stability, of course, and the cup entrance plane. This you can adapt, but within a certain limit, unless you don't use a special cup with a reduced entrance. Prosthetic impingement is a big issue. And here, especially if you use ceramic on ceramic and you get prosthetic impingement, it's a catastrophe, because it will break on the long-term run. And if you want to be safe, you always stay better with polyethylene, because this doesn't happen so rarely. And if you have a skirt, it's even worse. So the skirt is the worst thing you can do to restore biomechanics by a skirt. Never use it, and better to reorient the cup than use this skirt here, or this type of prosthesis. But we don't have only prosthetic impingement, we have also bone impingement. Why? The offset, yeah, but here in flexion especially. This is from Amstutz, a graph. Yeah?
Because of anatomy.
Sorry, what?
Because of anatomy.
Yeah, because of anatomy, and anatomy changes. Yeah, we are not aware of this that much, but anteversion changes. We use straight stems. Yeah, we don't have the modular stems. This causes then often earlier impingement of the bone. Yeah? And so this is sometimes a limitation. And patients in the beginning have often this impingement pain. Especially if you spare the capsule, it can be more often. This is an old paper, but it shows clearly that there is a limit of increasing the size, because if you go to 32 millimeters and even beyond, you avoid the prosthetic impingement, but there is you increase or there is no benefit for the bony impingement. So 36 millimeters seems to be a good option. Now, big heads increase the surface, decrease the tensile strength, but the cup position is important. This shows this paper here. So we have the component abduction angle between 25 and here 90 degrees in the experimental setting. And we see here that the tensile strength is increasing. So big heads don't forgive the position, a malposition of the acetabular cup. They make it worse. This shows this paper here. So in the normal position, 45 degrees with increasing head size, you get a decrease in the tensile strength. But if you have a malposition, a valgus position, you increase it. So nothing without any harm. So no benefit without any harm. Now coming back to the dual mobility, they are good. We use them more and more in this spinopelvic problems, but we have also other things like impingement, because this polyethylene inlay, this layer is also moving, and this can impinge here, so you can have debris also, and you can have psoas impingement. So these are the big disadvantages because of if you have a big head and this is rotating out, and you can have, of course, separation in a prosthetic dislocation, it's called. And we also, in patients with revisions, we also observe this. So this is a survey also analyzing the problems, and the inner prosthetic dissociation or dislocation is 1%. Where can be unpredictable, because of this issue of the position, and corrosion is a concern, of course. It can occur in the modular implants, and psoas impingement, as mentioned now. Now, polyethylene, you are used that you take the polyethylene off the shelf. The studies we know are mainly, so the old studies are done with this conventional polyethylene of the first generation, designed by Charnley. And interestingly, this is because nobody knows where the innovations has been done for polyethylene. This was in Europe and US, of course, but the first patent for vitamin E polyethylene was where? In Czechoslovakia. Nobody knows. Yeah? Here, see, this was the first patent, and then here Schaffner. This was the second generation by Lederer. This was Leoben here in Austria. So they modified this patent, and then the highly cross-linked polyethylene came up. Are they good, or do they have disadvantages? Highly cross-linking is a special treatment by irradiation, which makes increases the age of polyethylene. So there are disadvantages because it's more brittle and it can break over time. And so there has been the change to modify this, take out the free radicals with different techniques, and also put in vitamin E to prolong the survival of this polyethylene and prevent oxidation. These were early results, so the clinical outcome was really good. And what was interesting, that there was no difference between head size and on the long-term run. Here, 25 million cycles, the same with small and big heads. Here you see again, with increasing head size, no increase in the wear in the experimental setting. This is another more modern graph showing metal on polyethylene, standard polyethylene, metal on highly cross-linked polyethylene, and here oxinium, which is this ceramized surface with highly cross-linked polyethylene, excellent long-term results. So the wear is almost non-visible. It's almost the same as in ceramic on ceramic. And scratches. Scratches on the head are a big issue. So how do you reduce the head? Because this is an important thing. When you scratch over the edge of the cup, you get a scratch in metal more than in ceramic, which you don't get rid of. And this roughened head increases the wear tremendously. So there are instruments which help you to reduce the head over this edge without touching it. And this is crucial. Be aware of this, because when you have, this is the smooth head, no problem with highly cross-linked polyethylene, whatever you use, almost no wear. But if you have a scratch in the head, you significantly increase the wear, and more with cobalt chrome than with this hard surface, with ceramized surface. And even if you have this highly cross-linked polyethylene, only with this with this hard head, so ceramic or with the ceramized head, you have a decrease, and it's safer. So this is important. When you use or have to use metal heads, be aware when reducing the prosthesis. This is just showing, we'll go a little bit faster, the oxidation of the polyethylene and the different techniques, how this the highly cross-linked is produced, and vitamin E increases or decreases aging of the polyethylene ex vivo, but also of course in vivo. And here RSA data, you know, radiostereometric analysis is the most exact way how to measure it in vivo. And here's the penetration into the polyethylene with conventional polyethylene, longevity, which is highly cross-linked, and vitamin E, so another increase in survival. Metal on metal, I already talked about. The disaster ended here with this comparison of the study of resurfacing. There are clinics, high volume clinics, we still do resurfacing. Is anybody using still resurfacing or at your institution? No. Yeah. We also stopped completely, but the disaster started with these big heads where everybody thought when you revise resurfacing to a standard prosthesis, you just put in a big head and lift the cup inside, and this was the disaster because the cobalt chrome levels went up tremendously, and this had to be stopped and taken out of the market. Ceramic on ceramic is also long in the market, so there were early generations which had a survival of 83%, and the late generation about 96%. So it's also my standard access to use it in young patients, but what's difficult on the long-term run are the noises. Did you ever have a patient with squeaking? I mean, imagine you have a patient who is on stage as a dancer, and he's squeaking hip. It's impossible. So it's really loud. So people, when they go in the tram, they turn around. Unfortunately, I've had not the time to put in a video, but it's really terrible. It's and this is not an event which happens after the operation. It increases over time. Yeah, and nobody knows exactly. We have two proponents here. The Ecolate. This was extremely high. So this was known. Ecolate is a sounding hip, because there was a 63% of noisy hips. And in others it was not the case, not that much, as you can see here, the Secofix. But anyhow, I mean, you have to be aware of this, and especially in high active patients, as I mentioned before, you get this contact at the edge of the prosthesis, and this can be detrimental, because then you have more wear, and this wear probably can cause the squeaking. On the other side, there is another mechanism that you have bony impingement when the patients flex extremely. And after this, so when they go in, down and up, then it makes, and the reason is there is a separation of the head and it's not a dislocation, but a small separation of the head and the cup, and this separation causes a destruction of the film, immediately of the fluid film, and increasing the noise. And what's the original reason for this is unknown. Maybe these are scratches which are on the head and by time cause third body wear. So I'm more and more cautious also in young patients because of these excellent polyethylenes, which vitamin E and so on, and they are safer than this ceramic on ceramic. So be aware of this, especially in a patient who has high performance with range of motion and needs a big range of motion. So this is now just a summary, but I think I repeated it so often that I don't have to do it anymore.